Hello, everyone. I'm Christina Arangio here with Dr. Julie Morison, local psychologist and founder and director of HPA Live Well, with the latest episode of The Real Deal. How are you, Julie?
I'm good. How are you?
Good. I know today, as of this recording, we are now out of
The deep freeze.
the deep freeze. For the first day in 19 days, we have hit the freezing mark, which is just normally you'd say,
It felt like spring. Did it not feel like spring?
Yes.
I got out here and I was like,
yeah,
what is
spring
this?
in your step, right? This morning, like,
what is
what
this?
is it?
There
Somebody
could be a tulip.
lifted the bubble or something. Like, it just feels so
I know. Feels good.
much better. And here it is, 32 degrees. But anyway, yeah, it's just
We'll
it's
take
worth
it.
noting.
We'll take it.
Yes, worth noting.
fine.
And yet we're still in February.
We are.
So we're still continuing our conversation, and we have had, this would be our third episode
Yep.
with relation to eating disorders,
Yes.
because that's what this month is all about, awareness.
Absolutely.
And I know we spent a lot of time on talking about the different types of eating disorders and how they develop.
Yep.
But I remember when you were on the air with us last year, which we're going to do again later
Great.
this month, you had mentioned, GLP-1s. Am I saying that right?
Yeah, GLP-1. Yeah.
Weight loss drugs.
Yep.
It's a whole thing
It
with
is a
eating
whole
disorders.
thing. It's a blessing and a curse. Listen, I mean, so I think that they're so new that we don't really know what to do with them, right? What to make of them. They seem like a miracle drug for people who have struggled with weight loss for years and years and years, who struggle with obesity that increases the likelihood of other medical conditions. So on paper, it looks like a really good thing. And absolutely, for some people, it's a godsend. Right? Absolutely.
Especially
so
started with
again,
diabetes, right? That's how this started.
Exactly. Right. So those meds were used for a long time for the management of folks with diabetes. And then the piece about using them for weight loss, all of a sudden, turned the world upside down, because so many people do struggle with their weight. But what we have to remember, if those numbers were correct that we've said before about 1 in 5 females and 1 in 6 males will have an eating disorder in their lifetime, that means those commercials that are promising, 20% of your body weight lost in X amount of time, you don't know who your viewer is, right, for that commercial. That might be someone who has a medical condition that they're, oh my gosh, what a godsend. And then there could be somebody else who has disordered eating where it really stirs other things up. But it's also something that, we've seen problematic sort of secondary to them. So there's a couple of different problems that happen. And I think that, us talking about it today really isn't about you can't take GLP-1s. Okay. That is not the message, and that's not fair.
Right, because like you said, it's a godsend for some if used correctly. It does seem, though, that it is so readily available now, because what happened was they realized it was a side effect, right, of treating diabetes. This was regulating it, and then they noticed, tremendous weight loss.
Correct.
And because of that, it's like, wait a minute, we can market this for weight loss for those who are struggling.
Right. And also think about
with
weight loss with being overweight come other illnesses, right? So
trying to control the health
package
concerns.
Sounds great, and it's who doesn't want to be healthier? The problem is a couple of things. So our challenge is, first of all, somebody who struggled with their weight. Why did they struggle? Some people just have a propensity to be overweight. Maybe they were overeating. Maybe there's biological predispositions, genetics, right? Things like that. And those folks, or illnesses, and those folks absolutely could benefit from those medications. Yeah. For other people who've had disordered eating, so we'll take binge eating, for example. Okay. Right? So some people have struggled with binge eating disorder, and a side effect of having binge eating disorder is often weight gain, right? And so people who have binge eating disorder, they don't like that they're binging, but one of the things they hate the most and get called out by their doctors is their weight, right? And so they're like,
you need to lose some weight because we're worried about your health, and it could lead to all these other issues.
Right.
What can we do?
Right. Well, now we have this drug, right? So we can take this drug, and it'll calm the food noise, and it'll make you eat less. The challenge with that is oftentimes, yes, it calms the food noise. Yeah. They eat less. But one of the things that is a protective barrier for people who who have disordered eating, our goal when we take care of a patient in our office who has an eating disorder, our goal is what we call regular eating. Regular eating is eating within an hour of waking up and every 3 to 4 or 2 to 3 hours after that.
Okay.
And the reason that's the goal is because it fends off the symptoms of disordered eating, restriction, binging, then purging, right? Because if you were satiated for most of the day, not having these big drives towards hunger, you can really regulate the way that you're eating and regulate things like mood and things like that. So you have less likely the opportunity to engage in those behaviors.
Yeah.
So that's a goal. Problem is, if I were to say to someone, okay, they have binge eating disorder, still the standard of care is behavioral work, right? CBT, DBT, working on those skills in therapy.
CBT, DBT,
Right.
fine.
So, sorry, cognitive behavior therapy, dialectical behavior therapy, giving skills to replace those binge behaviors instead of needing to use the binge eating as the coping skill, teaching other skills, right? So that's our goal. But wait a minute, there's this pill or a shot.
Why do I have
that
to worry
can
about
make me
that
nuts.
stuff?
I don't have to. Do you know how hard it is to change your behavior? I mean, try to use your left hand if you've used your right all your life, right? That's really hard to do. And so what happens is folks, they take the road of, which you understand why, you take the road of those medications, but regular eating is very hard on a GLP-1 because you're not hungry.
Well, and that's what I wanted to talk to because I know weight loss drug side effects mimic eating disorder symptoms, right?
They do.
So there's 3 things that I saw, and I know you can expand on this for me, but so those symptoms or those side effects of weight loss drugs, feeling too full,
Sure.
skipping meals, and losing weight too fast, right? And they are very similar.
Yep. And think about the side effect of, quote, losing weight too fast, for example, or feeling too full. Those things actually add to other problems. So if you think about somebody who's losing weight too fast, think back to the first episode when we talked about what each eating disorder is, right? If we think about anorexia and the restriction that comes with disordered eating like anorexia, you're talking about, basic food refusal with significant weight loss. Well, that's a challenge because with that come medical side effects, things that we get worried about, right? We're watching electrolytes. We're watching things like arrhythmias. We're watching things, there's side effects like cold intolerance, hair loss.
When you're not
fatigue.
eating at all.
Right.
Yeah.
That's just from the behavior. We also talked about atypical anorexia, right? You don't have to be underweight to have those symptoms. You have to have a significant change in your behavior, right? Heart rate slows down.
Right.
Those types of things. So the people who are mimicking almost that restrictive behavior of anorexia, that doesn't mean they're out of the woods for those medical consequences that come with anorexia, right? So just because you didn't choose to restrict, you're using a pill or a shot to
That
now
is
not
restricting
eat.
you.
How are we in a different spot? The problem is, people a lot of times with anorexia, sort of their restriction starts over time and usually gradually gets worse and worse, right? It gets more extreme.
Yeah.
With GLP-1s, when you get that full dose, there really is a low drive towards food. So they're really, really restricting and really doing it quickly. So you're talking about people losing weight, percentages of body weight in just a short amount of time. 1 week, 2 weeks is a percentage of weight loss.
Wow. And then what does that do? I mean, I often wonder about this for people who, I guess they're being prescribed it because for whatever reason the doctor thought it was okay for them. It's not a diabetes issue, but they're using it for weight loss.
Right.
Just the psyche of this of, oh my goodness, I'm not hungry. Like, is there euphoria at first? Like, I'm not hungry. Right. This is amazing. And then you're like, I'm never hungry.
Right.
What goes through your mind?
I think it's different for everybody, and it also depends if you had a propensity towards disordered eating. So the problem is if I go into my doctor and I have a history of bulimia and I'm 46 years old and I go in there and I say I have a new doctor and I don't tell them that when I was let's make up when I was a teenager I had 16, an eating disorder, right? And I go in and I meet a new doctor and I say, I'm over. I feel overweight. Yeah. I'm perimenopausal. I've gained this weight.
What can I do?
Can I go on a GLP-1? And they look at your BMI and they're like, yeah, you're a little bit moving in that direction. Let's try a GLP-1. But they didn't know that by history I had bulimia. What happens to that person is all that old stuff comes back. Now, do I promise that means they're going to engage in binging and purging? No, I'm not saying that.
Yeah.
But there is a strong likelihood that they need to be watched much more closely, and that physician needs to know. But again, if they don't ask, they don't know. And if the patient doesn't tell you.
That, and we talked about this in our last episode too. So even if the doctor's due diligence, like, okay, let's slow down. How has it been for you before? Have you ever had any problems? Have you ever had any, disordered eating or, but if you're not willing to say, what can they do?
Right. Well, so now look at that again. So let's say that the doctor says, yep, okay. And they say they never ask you about the eating stuff. Or maybe they do and you calm them enough and fine, whatever.
Yeah.
That doctor may say, okay, here you go. If they don't say something about you need to engage in regular eating, this person just takes that drug, doesn't have the urge towards food, they will not eat. They won't have that regular eating. Now let's speed this up and let's be the insurance company that says, sorry, you were on this drug. I'm going to pull you off it. I'm not going to approve it anymore. So now the patient goes from being on medication, losing weight, not being hungry, and all of a sudden they go off the med.
And now they have a new eating disorder.
What we know to be true is that when you come off those meds, that food noise turns right back on. So whatever you had before, you've got again, because there's no sustained change there. So now if I'm not regularly eating, I now have to figure out how to do that again.
Exactly.
With the same food noise I had before.
But now I'm not on the weight loss drug
But now
anymore.
let's create another issue.
Okay.
So that tells you, well, you better be regularly eating even though you're on the weight loss drug. Oh, well, they'll just eat healthy regularly. Let's pretend to do that. Everyone needs to remember back to, your Psych 101 class when you learned about Pavlov's dog, right? That bell goes off, the dog's hungry.
Yeah.
Problem is, the GLP-1s turn off the bell. So you have no propensity towards food. So why am I eating regularly? It's not that I didn't want to. I didn't drive towards it. So the problem is that we see how we kind of like chase our tail. So if you don't stay on those medications, what's next? And I think that's what we need to plan for.
Okay, more to come. What do you think is best to focus on? Because we've already gotten into a little bit of how it can trigger new eating disorders. Sure. So what do you think we should focus on here when we go to
Well, I think what we need to do is, one, talk about what are the questions you need to ask, what are the preparations you can make to sort of fend that off. We're not going to beat them, so we got to join them in a sense. So what do you need to do if you're going to be on a GLP-1?
Okay, important. All right.
Because I'd like to beat them, but I guess I have to do it.
Right. All right, we're back with more from The Real Deal. Keep it here. Welcome back to The Real Deal, talking about weight loss drugs and eating disorders. Serious concerns here, and I have to say, I do not envy your position as a psychologist, and I know this is how your practice first got started. You do everything now, but I mean, it seems with weight loss drugs being so new, but with everything you're saying, that this could end up being just a whole other issue where more people are coming down with, suddenly finding themselves presenting with eating disorders that hadn't before because of what happens to their bodies. Yeah. And we're not even talking about everything that happens to your bodies, because there's those gastrointestinal symptoms I've heard of, and just there are challenges here. But we're speaking about it from the eating disorder perspective. So we said this, they're not going away. It's way too enticing for people, and the thought of I can finally be a weight that I want to be. Right. Without, knowing all the things it can do. How do you navigate this?
So the first thing, exactly, right? We're not going to take them off the market.
Right.
Because you and I sitting here today aren't going to do that, right? So where can we put our efforts? And I think our efforts are in protecting the people who are listening to this, right? Or who you talk to because you've listened to this. So I think the bigger thing is this, a couple of things. If you're going to go on a GLP-1, you need to do a little soul searching. Have you had an eating disorder before? Have you had poor body image before? You need to kind of do a little soul searching and make sure that you're identifying that. Now, whether you're going to tell your doctor that or not, and I would encourage you to do it.
Yeah.
Now, that recognizes that you may be sort of self-selecting out of using medication if you tell them, because it is contraindicated, right?
Yeah.
But let's say you acknowledge it and you still get the medication.
Okay.
It's not unfair to want to be a healthy weight. It's not bad to want to look your best. It can even be just because you want to look your best. That's okay.
Yeah.
I'm not there's no judgment there. But we got to do it in a way that would be sustained, right? Because we want to say that we don't want to have to be on a medication for forever. And some people are like, I don't care. I'll be on a medication for forever. I hate how I feel.
Right.
But what we want to do is be prepared for, what if you can't stay on the medicine? What if you have those gastrointestinal problems? What if you have to come off for whatever reason? Because there are a slew of side effects, right? And those are the ones they know about. These drugs are new.
Very new. I think about that so often when people even talk about it.
Because they're not sure,
the research isn't there yet.
My feeling about it is this: get co-occurring nutrition guidance and or therapy if you have had an eating disorder in the past or poor body image.
Okay.
Because what we wanted, and at minimum, say you don't even do that, you want to work on regular eating while you're on these meds, even if you're not hungry. So think about back to the days when you had this little newborn, right? And you wake them up at this time and then 3 hours later and
every
this
3
time.
hours.
And why did we do it? We did it, we thought it was to just feed them. It was also to get them on a schedule, right? To make them hungry in a predictable way.
Yep.
And so one of the things that people can do is what we call mechanical eating. Eating not because you're hungry, but because you're supposed to.
Okay.
So that allows you to have those healthy foods that you want to be having and, having shakes and things like that. It keeps your nutrition up and it keeps your body used to eating regularly. And that is the best we can ask people to do, even if they're not hungry. They can eat a calorie amount that is reasonable for their weight loss goals and eat in a regular fashion to allow them to keep their body trained on regular eating.
So this is what's in my head. It seems to me, but I don't know how much guidance people are given when they go on. Like that to me should just be standard procedure for anyone, or at least this is what you need to do to prevent some other problems.
Right.
And then I'm always thinking about that conversation in the doctor's office where, if it's decided you're going to go on it, do they at least say, okay, here are the things you need to know outright? Or are people just like, listen, you are a little overweight. Let's, we want to watch your heart health and so many other concerns. So let's do it. Or, are they being taught in medical school, to say, okay, we have this concern and there are gastrointestinal issues. You need to be aware of all the side effects. Does that stuff even happening? Because to me, if it's talked about more, then you would think people would be more inclined to be like, ooh, okay, I really got to watch these things.
I think the answer is yes and no. I think it depends who the provider is. Yeah. I think that we also have to remember what medical system we're in. Physicians are doing everything they can to get patients in as quickly as possible because someone's got the flu and someone's got strep and somebody's got this, headache that won't go away. And they're trying to get everybody in. And so you're coming in there and you're saying that I have this concern and I want to be considered for this medication.
Yeah.
And the doctor is going to do the best they can in the 3 minutes that they have to talk to you. And they expect that, you present yourself well and a good reason why you want to take this medication, that you've thought through the fact that you're going to have to manage this. Now, did the doctors take that time? I don't know. Does a pharmacist make a recommendation? I'm not sure.
That's why we have to basically
But that's why we have to
make
talk
it clear.
about this,
yes.
right? Is that you're not really worried about your right the second self. You're worried about yourself down here of, I'm doing this because I want sustained change. If you don't eat alongside these medications, that sustained change is challenging. And you also need to be careful about a couple other things. And I think, the one thing I'm starting to get a little bit worried about, and I'm really good at, it's crazy that I'm trained in helping people to not worry, but this is what I would worry about. I'm really good at worrying.
We all are, aren't we?
These meds are going to change from shots to oral medications.
Already are, right?
And we see that, right? We worry about the opioid epidemic, right? Where, people are taking pain medications in a scary way. And then who grabs those out of the cabinet because they're going to a party? Your kids. A kid grabs those. Well, what's preventing kids from then taking an oral medication because your son or daughter is not feeling comfortable in their skin because someone bullied them at the lunch table today.
Right.
And if you're not watching what it is, thinking about where is that going, right? And I think that that's where I'm starting to get a little bit nervous too, is the sort of the regulation. This stuff is getting dealt, almost the way that pain meds, we realized that those were getting dealt out so fast, and that it's almost like you can't put the genie back in the bottle.
Right. And we were talking in between segments here that now it's even advertised in some cases where there's like a little drop you put in a drink, like a little droplet, and then that's no injections, no injection site concerns. And, you know.
And we also see stuff like, in health spas and things like that. So people don't, and the cost has gone down. So the thing that prevented people
even more so
from going on these medications was that insurance wasn't doing it and you had to pay cash. And cash was like $1,500 a month.
Not anymore,
so
right?
people couldn't swing that. Now it's not.
No.
And so now the rules with a lot of the insurance companies is that you have to be in a program, is what they call it, to be on these medications. But first of all, it's not stipulated what those programs look like.
Okay.
And essentially you could get away with maybe one talk with a psychologist or a therapist of some sort, may or may not be trained.
Is that happening more and more, though? Insurance companies, isn't
it
that
is,
at least one positive thing or not really?
But think about it. So let's talk about what a copay is. A copay for somebody might be $25 to $50.
Okay.
If I say that I had an eating disorder and I'm going to go talk to this person who's a therapist and they're even in my doctor's office and I have to go pay my copay and it's $50 just for easy math, or we'll make it $25, even better insurance. So it's $25. I'm going to go once a week. At the end of the month, that's $100 in terms of copays. Those drugs now online you can get at about $130. Why wouldn't I just pay my extra $30 and not try?
Online, you mean, and not even deal with it?
Why would I bother?
Why do I go to my doctor? I don't need to. You can get these things.
And these therapists might say to me, maybe you shouldn't take this. Why do I want to do that? Why do I want to work to make behavior change when I can just go get the drug? You know what? I'll call those guys if I need them.
Yeah.
Now you see what the problem is, right? Because now we're dealing with a fire drill instead of co-occurring therapy, right? Doing this alongside. And so while you try to, catch up with these things, and I like that insurance is doing what they're doing, and making sure that they're in some type of program, because there's copays and the cost of the drug is going down, patients are going to make the cost-benefit analysis of for $30 more. I'm just going to do what I want to do.
And of course, what I keep thinking is, well, this is all about self-regulation. But the whole problem is, if you're having any issues with disordered eating, you can't regulate well, or you struggle with regulate.
You've struggled with it,
right?
Or you're promoting, you have negative body image. That is, I would like to self-regulate, but I'm so distressed that I can't do it today. I'll do it tomorrow. Or I'll call someone later. Or you know what, my body image is going to get better if I just lose about 5 pounds. Now I've lost 50 pounds, and now my identity is now tied to my weight loss.
Yeah.
Right? And we've seen things, even relationship disruptions. When people have big changes in their lives, and this is a big change for people, we can see disruptions in that. So it can be a really multifaceted thing. At the same time, some people really need this to keep that weight off, and they need insurance to pay this, and then they can't. And these medications work until they're off of them, and then they don't work anymore. And so those folks are really grieving.
So because my understanding, again, is that you kind of need to be on these for life. Is that not true? I mean, people go on and off them because they don't like the effects they're having, and then you're yo-yoing. That's got to be a whole other potential for disordered eating, no?
I think they're learning more and more. Remember, these are drugs that have been used for a long time, but at the same time, they're new. Yeah. New for this.
I know, and I just wanted to correct something. I said, there's no research on them. Obviously, there's some research if they're allowing it, but it is still so new that we don't know long term.
Yeah.
Right? I believe that's fair to say.
That is fair to say. Yeah. I think it's very fair to say,
okay.
Especially for the use of these drugs for just weight loss.
For just weight loss,
right?
Yeah, not diabetes, which has been studied longer.
Right. Yeah. And we just don't know.
Yeah.
We just don't know. And so I think that that's the biggest concern. And I think that we have to have these conversations. You have to be willing that if you're going to take a medication, I mean, look, when this boils all down, here's the thing. This is a buyer beware, right? People, if you want to lose weight and use a GLP-1 to do so, you can call your doctor and probably get on it.
Yep.
Bottom line,
it's getting easier and easier and easier.
Absolutely.
So is it something where we, I'm trying to think, how do you reach people? As parents, you have conversation, like, what can you do? And then you turn your teenager off. If you even try to bring it up, but do we need to have these conversations? Because I feel like so much of it is still hush hush.
Well, I think one of the things we can say is just the bare basics of it's not natural to not eat. Your body is, you come out of your mother and you're hungry, right? You need to be fed.
Yeah.
It is a normal human drive to have hunger, and that's not bad. And if a medication takes that hunger cue away from you, it suggests that something really big is happening with those medications. Regular eating is still important. And I think that as parents, what we're doing, whether it be about GLP-1s or not, if we're driving home the need for kids always to have sustained, healthy nutrition that is regular eating, it will force them as adults who make these decisions to recognize that, wow, I'm taking this medicine and I'm not eating regularly. That's against what my mom always taught me.
Right. So we have to set the example. It starts with us being on
and if
our
you
kids
are a
with
parent,
regular eating and good nutrition.
And if you're a parent who's on these,
oh boy,
you need to know your kid sees what you're doing. And so even if you say, well, it's just because of me, my health, these kids think you are them.
Of course.
And they are you. It is so connected that it's hard for them to separate.
It's a lot that we unpacked here.
I know. What a February.
I know, my goodness. But I think the most important thing is that, people need to be more aware. And like you said, just try to set those good habits. Start early because, you could end up setting, hopefully, the right course for your child so that maybe they, hopefully, avoid these things down the road and won't even need to think about a GLP-1.
Yeah.
Thanks for talking with us about this.
Absolutely. Thank you for the opportunity.
Of course. We're back next week with The Real Deal. Thanks for watching.